Hello, welcome to Womack Army Medical Center, to the Obesity and Metabolic Pathway. My name is Gregory Pierce. I'm one of the bariatric surgeons. I am the chief of bariatrics, and this will be our orientation to the program. Just some background on our program. We have been performing bariatric surgery at Womack Army Medical Center since the early 2000s. We do offer lifetime follow-up. I've seen several patients who had surgery early in the 2000s and continue in our program. We perform several bariatric surgeries per year. In the year 2021, we performed over 120 bariatric surgeries at our medical center. We have multiple surgeons and nurses and a multidisciplinary team. Currently, this is our staff who help us on the bariatric team, to include nurses, our PA Brittany Howard, and to include Kathleen Sopp, who is our dietitian. Today we'll be talking about what is obesity, why treat it, how do we treat obesity, who qualifies for surgery, what surgeries are available, and what is the lifelong commitment after having surgery. What is obesity? Obesity is defined as a BMI greater than 30. BMI is a body mass index that is calculated by someone's weight in kilograms over their height in meters squared. Overweight is considered a BMI of over 25, and morbid obesity is generally considered a BMI of 35 or greater. Here's a chart of height and weights where one can calculate their BMI. Why treat obesity? Obesity increases the risks of the following: arthritis, cancers. With the recent COVID pandemic, one of the major factors that was predicting severe COVID illness or death was the weight of the patient. Increases risk of mental issues such as dementia, depression. There is a significant correlation between obesity and diabetes, with gallstone disease, fatty liver disease, which is another name for NASH. Headaches and migraines are found to be worse in obese patients. There is significantly higher risk of heart disease, high cholesterol, high blood pressure, infertility, sleep apnea. Obese patients live shorter, and there's risk of stroke. You can see here that obesity affects many organs in the body, from head to toe, joints, liver, lungs, heart, brain. Obesity accounts for more than 280,000 premature deaths annually in the United States. And weight-related illnesses now exceed smoking as America's most preventable cause of premature death. A large amount of healthcare costs are placed into treating obesity, and a large amount of the United States, 42.5%, have a BMI of 30 or greater. How is obesity best treated? There's lifestyle modification, there's also medical management, and ultimately surgical management. Lifestyle modification, talking about diet and exercise, medical management, there can be medications to treat it. Lifestyle modification is essential for weight loss and weight loss sustainment. Some pillars to have weight loss would be nutrition, diet, activity, exercise, getting good sleep, and having good management of stress. It's difficult for anyone, I think, to achieve all of these. We're all fighting to improve our diet and our exercise, sleeping well. In today's world, it's difficult to achieve this. Traditional diet therapy for morbid obesity. There have been multiple controlled trials that have assessed people who have undergone a rigorous diet and exercise regimens, and some of these trials have place people in a surgical group and a non-surgical group, and in the non-surgical group, patients can lose weight with rigorous exercise and diet and follow-up, but invariably these patients long-term regain that weight. It's very difficult to lose weight. One of the more famous trials was you may remember, the Greatest Losers TV show, where patients would exercise and diet on TV. They had their personal trainer and they would do very well initially, but almost all those patients, after they were off the program and on their own, would gain their weight back. So they would not be able to sustain that. So it's very difficult for one to lose weight with diet and exercise, and if one is able to achieve that, it's difficult to maintain the weight loss. One way to attempt to achieve weight loss is medications. These usually don't result in much more than 5 to 10% overall weight loss. The medications that treat weight loss can cause a sense of fullness, but they do have some side effects such as diarrhea often. They are temporarily used with stalled weight loss, and they're not a permanent solution, as the medications are stopped after a while and often the weight is regained. Other ways to treat weight loss would be endoscopic treatments. These are not very common or universal, and often they are needed to be paid for up front, and they're not offered at Womack or medical center. But some of these options are balloons that are placed in the stomach temporarily, or an endoscopic procedure such as an endoscopic sleeve. The surgery has been proven to be the best long-term effective way for weight loss in obese patients, as stated by this NIH National Institute of Health consensus statement. Only surgery is proven effective over the long term for most patients with clinically severe obesity. So who qualifies for surgery? Those who have attempted weight loss and not been able to achieve it with lifestyle modifications. One needs to have a BMI of 40 or greater, or 35 or greater with comorbid illness such as the ones we discussed earlier: hypertension, diabetes, coronary artery disease, or uncontrolled or poorly controlled diabetes with a BMI of 35. What are the surgical options for weight loss? There's about 4 surgical options we do here: sleeve gastrectomy, gastric bypass, what's called the single anastomosis duodenal ileostomy, it's often called the SADIES or the SIPS procedure, or the Biliopancreatic diversion with the duodenal switch. For those who have had previous bariatric surgery, revisional surgery is an option here also. The majority of the surgeries we do at our institution are done minimally invasive. That's either laparoscopic or robot. The sleeve gastrectomy, that is currently the most common procedure done in the United States. Not the most common procedure we do at our institution, but the sleeve gastrectomy, if you picture the stomach kind of like a football, that's about the size of our stomach when it is inflated or full. With the sleeve gastrectomy, we essentially make the stomach look like the shape of a banana, and approximately about the same size as a banana, by removing that greater curvature of the stomach. It's purely restrictive, and it is the most common surgery. You can see here on the greater curve that portion of the stomach is removed, the resected stomach. The advantages of the sleeve gastrectomy is that it has low complication rate. While all the bariatric surgeries have what I would say a low complication rate, the sleeve probably has the lowest complication rate as far as leaks or bleeds. However, all the surgeries do have their a low complication rate. The amount of excess body weight loss after a sleeve gastrectomy is about 50%. So if one had if one had 100 pounds of excess body weight, that would mean that they would on average lose 50 pounds of the excess body weight after a sleeve gastrectomy. The disadvantage of the sleeve is that it is irreversible, that once that stomach portion is gone, it's never coming back. It may worsen reflux. About 20 to 30% of patients can have reflux where they didn't have it before surgery, and those who did have reflux before surgery, it can worsen. And there is a higher rate of long-term weight regain when compared to the other surgeries offered. The Roux-en-Y gastric bypass, that is both a combination of a restrictive and malabsorptive surgery. You can see on this slide that the stomach remains intact in the abdomen, but it is divided so that there's a pouch of the stomach that is connected to a portion of the small intestine, and this is later connected in a Y fashion where digestion occurs with the secretions from the liver and the pancreas. This bypasses about 200 centimeters of these 7 meters of our intestines. So about 2 meters out of the 7 meters are bypassed. The advantages of the gastric bypass is that it has been around a long time. The sleeve has been around about 10 years, so it's kind of a new kid on the block when compared to the gastric bypass. There's not as much long-term data. The gastric bypass has been around since the 1980s. It has excellent weight loss, a little higher on average than the sleeve gastrectomy, about 60% of the excess body weight. It is the best surgery out there for gastric reflux. The disadvantages are there's a small increased risk when compared to the sleeve with perioperative complications. There's more rearranging of the intestines, but it is again a small risk and it's still a low risk of overall complications. There is an increased risk of vitamin protein malnutrition when compared with the sleeve, but that again also remains low. The single anastomosis type duodenal switch is also a surgery that we offer. This is a newer variant of the duodenal switch, was recently endorsed within the last 2 years. This is a more aggressive malabsorptive procedure when compared to the gastric bypass. About 4 of the 7 meters are bypassed with this surgery, with usually 300 centimeter common channel. This is usually considered in those with a BMI of 45 or greater. The excess body weight loss is higher than a sleeve gastrectomy with around 80% excess body weight loss. And the weight regain seems to be lower when compared to the sleeve or the bypass after surgery. There is an increased need for nutritional compliance with taking vitamins after this surgery. Essentially what this surgery is a sleeve gastrectomy combined with a bypass of a large portion of the intestines. So it's both malabsorptive and restrictive. And we have had very good results with patients who have had this surgery. The final surgery that we offer that I will talk about is the duodenal switch. This combines a sleeve gastrectomy with a malabsorptive procedure. It's more aggressive as far as malabsorption when compared to the SIPS procedure. It bypasses all but 100 or 150 centimeters of the small intestine. There is a slight increase in complication rate when compared to the other surgeries. However, it still remains low, and this surgery is usually reserved for the super obese or patients with a BMI of 50 or greater. This has the greatest weight loss of the surgeries which we offer, with an excess body weight loss of up to 85%. And it seems also to do well with preventing weight loss retention after surgery, or weight regain after surgery. The goals of our bariatric surgical service: we want to provide comprehensive pre- and post-operative educational and support pathway. I do think that our program is an excellent program. We try to make the preoperative process an enjoyable one, but also the surgery itself is not the only thing that will change your life. It's the education and the lifestyle habits And that is the education is best obtained before the surgery, and not get the surgery and then figure out what's going on. So usually the preoperative process takes around, on average, 4 to 6 months. And post-operative, we follow our patients. We'll follow them lifelong on a yearly basis. Our goal is to provide the highest quality surgical care, to choose the best procedure the first time. One of the benefits of us being a non-profit facility is that we can offer what we think is best, not what makes the most money or what is easiest for our patients. And we offer total care of our patients. We want to keep them in our system, treat any complications or any revisional surgeries that are needed. How does bariatric surgery work? It works with the combination of the following things: restriction, malabsorption, appetite suppression, hormonal effects, which we don't necessarily totally understand, and also a commitment to healthy habits, diet, and exercise. As I said, the surgery is a tool. Like a hammer itself can't build a home. The surgery is designed to be a tool to help you not just lose weight, but to live a longer and happier life. What is the lifestyle after bariatric surgery? I have rarely met a patient who was not happy that they had bariatric surgery and didn't feel like it was a positive thing that changed their life in a great way, that they live a happier and healthier life. But it is a lifelong commitment. There's a commitment to ensuring that you get your vitamins and your nutritional supplements and protein intake, healthy eating habits, smaller portions, commitment to physical activity, follow-up care, and support groups, which offer great support. For those who've already had bariatric surgery and are looking for revisional surgery, we do offer that here. The revisional surgery is often sought for if one has not met weight loss goals or had weight regain. It is a higher risk than an initial surgery, and we do have patients re-enter the program to complete the pathway. And not all patients are candidates for revision, but we certainly will assess and be happy to see anyone who is interested. So what does the journey to bariatric surgery look like? It is somewhat laborious, but necessary. There are things that we need to do to help you get the knowledge, the skills, and also help us know which surgery works best. Part of the preoperative workup includes endoscopies, evaluations with a multidisciplinary team such as nutrition and psychology. All these are required both in the military and in a civilian setting. And surgical candidacy does depend on pathway compliance, understanding, and at the end, full bariatric team approval. We no smoking or illicit drugs for bariatric surgery. So I think the most important point to take out of all of this is this something that is for you? And I think, again, I have rarely met a patient who wasn't happy that they did it. It is not necessarily a cosmetic or a weight loss surgery. The important part is that it is a metabolic surgery, and it is a surgery that will help you live a happier, healthier, and a longer life. For patients with diabetes, there's a high rate of cure. For those with hypertension, reflux, high rate of cure. The toll that excess weight takes on the body is lifted, a lot of that, and patients can live a happier, healthier life after surgery. I think that's the main take-home point. In summary, bariatric operations are currently the best long-term option for sustained weight loss and correction of weight-related health problems. A multidisciplinary pathway improves patient preparation and long-term outcomes, and lifelong patient compliance with lifestyle changes is essential to sustained weight loss and health benefits. So this completes the orientation. If you are interested to sit down and talk with us, Even if you're not 100% sure you want to have surgery, we would love to meet with you on an individual basis to talk more about the program. We have providers who will be happy to meet with you, including myself. In order to meet with us, please call the office phone number 910-907-0787. Let them know you've completed your orientation, and we will go from there. If you have any questions, issues, or problems during the preoperative process, you're welcome to email me directly at the email at the bottom. I wish you nothing but the best. Hope we can help you in your journey to improve your health and happiness. Thank you.